Aida Nguyen, with geriatrician with the Department of Geriatric Medicine at JABSOM. I serve as the course director and facilitator for the series, and we are really glad that you are joining us as we resume our monthly Geriatrics Echo series after several months of hiatus due to COVID upending most of our lives. So, next slide, John. Oh, yeah, get to the slideshow. Great, next slide. Yeah, so just to point things out, as we start off today's session, we want to acknowledge that tomorrow is November 19th, and it's National Rural Health Day. And we need to let you know that this is the reason why the ECHO model even exists. It's to support our healthcare providers and our workforce who work in rural areas by providing education that is free and accessible online. Next slide. So yeah, a little bit about ECHO. This serves as a forum for mutual teaching and learning from experts and from each of us in the front lines. So as the ECHO model goes, everyone teach, everyone learn, and it will take all of you to create this community of learning. Next slide. A little bit about our format. After a short lecture from some experts, we will share expertise from the rest of the interdisciplinary team and then open up for case discussion. We invite you to share any geriatric cases, even if it's on a topic not related to today's lecture. Our interdisciplinary team is willing to share our collective wisdom with you as well. We only ask that you keep everything HIPAA compliant for discussion. Next slide. So we commit to maintain and safeguard the confidentiality of information shared. All case presentations must be de-identified and HIPAA compliant. We want to create a safe learning environment, foster a culture of mutual learning and encouragement. And just to note that ECHO case consultations do not create or establish provider-patient relationships between any ECHO specialists and patients whose cases are being discussed in this ECHO session, in this ECHO setting. Next slide. So if you've never joined us before, we run this series on the second Wednesday of each month from 12 to 1 as a 1-hour session, and we usually provide continuing education credits for physicians, nurses, and social work. This is our calendar for the next few months, so you can plan ahead and join us. As you can see, we will be sharing how we adapt geriatric care in the time of telemedicine. If there are topics you would like us to cover in the future, please let us know in the chat box and when you complete the evaluation forms. Next slide. We have some Zoom logistics. Move your mouse to the bottom of the Zoom screen, access the mute and chat tools. Next slide. Click on that chat tool and enter your name, your discipline, and organization so we have a record of who attended, and then press enter. Next slide. And then click on the mute button on the bottom left when you are not speaking. And of course, we want you to unmute when you want to speak up. Next slide. So in order to receive CME, you have to register on the Zoom link, which you did actually, otherwise you couldn't come in at all. And then you also have to complete an evaluation form that is on the website as well. I think John will also post it in the chat box later on during the session. Just to let you know, the CME activity is sponsored by the Hawaii Consortium for Continuing Medical Education. It's a joint venture between the Hawaii Medical Association and JABSOM. Nurses can also claim CE credits. Usually we try to get approval from the National Association of Social Works to get 1 hour of CEUs. But we apologize that we were not able to get it this time for today's session, but we promise we will resume it beginning in our next session in December. Okay, next slide. Okay, just by way of introductions, I introduced myself a little earlier, but we also have Mary Gotham. She is she's going to be part of our hub team here. She is currently retired from the Hawaii Department of Health with decades of experience in public health nursing. So Mary, if you want to just wave hello to everybody. That would be great. Also on our team here, we have Sarah Tompkison. She is a licensed clinical social work with 41 years of experience in geriatrics, mental health, and long-term care. And she has had many, many years at the VA. She also served at Halekuwiki for memory care, and she's currently part-time social work at Central Union Adult Daycare Center, program. And then, of course, we have Chad Kawakami, who is a PharmD and an associate professor at the School of the College of Pharmacy. Anyway, so at this point, I'd like to actually invite the audience to introduce themselves as well. Let me see, how many do we have here? We have a lot. Okay, so I'm sure we have time for everybody, but let me just go quickly through here. It looks like we have lots of familiar names and faces, and that's really exciting. And I was going to say, if anybody has a phone, but it looks like everybody's online, so that's fantastic. Anyway, I'd like to introduce us to our guest speakers. Today's topic is medical reconciliation, medication reconciliation during COVID. And today's talk was prepared by 3 PharmD students supervised by Dr. Chad Kawakami at the University of Hawaii Daniel K. Inouye College of Pharmacy. Dr. Kawakami has disclosed that neither he nor his pharmacy students have any relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. So at this point, I'm going to open it up to Chad.
Good afternoon, everybody. Thank you for taking time out of your day to join us. I just wanted to introduce my pharmacy student team. We have Joe Joyce, Tyler Young, and May Sistoza. They're 4th-year pharmacy students at the Daniel K. Inouye College of Pharmacy. And the reason why I have them doing this presentation is because a lot of our pharmacy students, and during their last final years, they're in clinical rotations. And one of the very important roles that they do, roles and services that they provide is assisting the healthcare systems on medication reconciliation. And as you know, COVID has kind of put things up on end, and they've had to adapt in the ways that they do medication reconciliation. So we're hearing their strategies straight from them. So at this time, and without further ado, I'm going to kick it off with Joe, who's going to start the presentation. Joe.
Thank you so much, Dr. Kawakami. I believe, May, are you starting?
Yeah, I can start it.
Okay. Sorry, excuse me.
Alrighty, hi everyone. So we're going to go ahead and start the presentation. Today we're going to be discussing medication reconciliation during COVID, specifically focusing on telemedicine. Alrighty, go ahead, next slide. All right, just a little background on COVID-19. It's obviously an infectious disease that has spread, and it's now currently a pandemic. There's no medications available to prevent its transmission, and vaccine trials are currently underway. So public health strategies include quarantine, social distancing, and wearing a mask, especially to note that healthcare workers, especially those caring for COVID-19 patients, are at an elevated risk of exposure. Next slide. But since we have this major focus now on telemedicine and telehealth because of COVID, we also have to realize that we're catering to the geriatric population, and our treatment approach, even with telemedicine, is the same, and that includes the 4Ms framework. So what matters, meaning aligning the care with the patient's specific health outcome goals, such as your end-of-the-life care, keeping them comfortable, medication, ensuring that they're age-friendly medications that does not interfere with the other Ms, mentation, preventing, identifying, and treating depression, dementia, and delirium, and mobility, ensuring that older adults move safely in order to maintain function and do what matters. I also wanted to point out that the medication reconciliation and that medication list is very important when it comes to touching upon the 4Ms. The medication list should reflect what matters to the patient. I mean, we're talking about geriatric patients, so oftentimes they see many different providers, including cardiologists, nephrologists. So having an accurate and good medication list is a starting point to the 4Ms. We can evaluate whether the medication affect mentation and mobility, but also assess whether there are any drug interactions or adverse reactions. Next slide. So in response to COVID-19, there has been this push to look at options for healthcare workers to care for their patients remotely, and that's through telemedicine or telehealth. I found this really great quote that quote that basically sums up that telemedicine may have started with COVID-19, but it's here for the long term. So just quickly, telehealth is a broad range of technology and services that provide patient care and to improve healthcare delivery system as a whole. So that includes providing training, administrative meetings, as well as medical education, while telemedicine is more a remote service. It's specific. So it means the practice of medicine using technology to deliver care at a distance. Next slide. Also wanted to point out that there are giant leaps from for the evolution of telehealth from back then to now. So we foreshadowed telehealth in 1924 in a depiction of a radio doctor where we see a doctor and a patient in a television screen. In 1948, there was transmission of radiologic images by telephone, which is the longest distance it's ever been at 24 miles. In 1959, clinicians at the University of Nebraska used a two-way interactive television to transmit neurologic examinations to other medical students across campus. And then in 1960s and 1970s, we did see the expansion of telemedicine. It was becoming more widely accepted, and there was more support by federal agencies. Also during that time, the U.S. Indian Health Services, NASA, and the Lockheed Company joined in sponsoring this program called StarPack, which tested satellite-based communications to provide medical services to astronauts and to residents of an isolated reservation. Next slide. And so what about telehealth today? Well, 71% of patients had considered telemedicine during the early months of COVID. About 33% of them, about 33% increase of telemedicine adoption from the previous year, and 83% of patients expect to use telemedicine after the pandemic resolves. Next slide. And so as technology advances, so does the widespread affordability and access to these telemedicine tools. So we know that much of the US population already has online video chat apps like Skype or FaceTime, and they have access to computer or mobile devices, but you're probably thinking that a 70-year-old grandma probably doesn't have this kind of technology available. They probably wouldn't even know how to use a smartphone, but statistics actually show different. So this was a report completed in December 2019, which shows that majority of adults 50 and older do have smartphones. Even at 70, about 62% have one. And also that 9 in 10 adults ages 15 and older who own smartphones actually use their smartphones daily. Next slide. So what are they doing on their smartphones? Basically, your social media. So most adults ages 50 or older use social media on a regular basis, and that's primarily going to be your Facebook. 3 in 4 adults ages 50 and older use at least one social media platform, and most older adults use technology to stay connected with their friends and family, although not necessarily through social media. They do use other services such as FaceTime, phone calls, and messaging. Next slide. And so what other what other services do they use? Well, most commonly they're used to gather information on the fly, so surfing the internet, sending or receiving IM or emails, but they also get directions or traffic info and such as that. So I will go ahead and give it to Tyler, who will talk more about the telemedicine.
Hi, my name is Tyler, and I'll be taking over for about the middle portion. Could we go to the next slide, please? Okay, so I'm going to talk about telehealth and Medicare for a little bit. In 2014, Medicare expanded to include telemedicine in rural areas and to areas that have a shortage of healthcare professionals. And they also put out a quote on to say that during COVID-19, doctors and other healthcare professionals can use telehealth services to treat COVID-19 and also use it for other medically reasonable purposes from their offices, hospitals, or their own place of residence as of March 6, 2020. So they personally endorsed it. And also Medicare telehealth services can include office visits, psychotherapy, consultations, and medication reconciliation, which is what we're talking about today, and certain other medical health services that are provided by an eligible provider who's not at your location using an interactive two-way telecommunication system. Can we go to the next slide, please? And just a brief rundown of some services that are provided by telemedicine. It can provide consultations between specialists and PCPs, since video and phone communication has made it very easy for PCPs to contact specialists. Same thing for imaging, as now X-rays, CT scans, and other types of imaging can be sent very easily from one healthcare professional to another. And also very easy to do patient outreach, since now providers can communicate and patients can communicate with each other very easily by video, phone, text, or internet. It can also provide consultation for common conditions that might not require a doctor's office visit, like allergies, asthma, diarrhea, sore throat, and many other small things. And telemedicine services can range widely by specialty, such as like a surgeon can do post-op check-ins with patients, gynecologists can provide birth control counseling by phone or video, and endocrinologists can have like a live chat with their patients to discuss lab results. Can we go to the next slide, please? So this is a brief, I'm going to make this brief of some rundown of some disciplines in telemedicine. There's one for almost every discipline, but we'll just cover these few. Telenursing, it uses utilizing remote technology like video to provide consultation and conduct patient monitoring, basically. This is very much growing in favor due to its low cost and easy access to patients, and it can help with monitoring and diagnosing small conditions like I mentioned in the previous slide. There's also telepharmacy, which allows pharmacists to provide counseling and medication monitoring over the phone or by video call. And patients may also get a refill if the company lets the pharmacist do so. For teleneuropsychology, neuropsychologists can do consultations and assessments over the phone with patients that have or are suspected to have cognitive disorders. Standard evaluations techniques are implemented to assess the patient via video, of course, and telerehabilitation, utilizing technology, usually video, to perform clinical assessment and therapy for rehab patients. Since this is a very visually strong discipline, video conferences are very helpful for this one. Can we go to the next slide, please? So some examples of telehealth broadly. The most common that most people are probably using is live video conferencing, which is live video conversation with a patient and their provider. And there's also something called store and forward or asynchronous video. It's basically the electronic delivery of a patient's health history. It's uploaded to a server and then it's sent out to all of the proper recipients at some point at a later time when it's most convenient for the recipients. And email platforms may also be used for this purpose. Next slide, please. And there's also remote patient monitoring. A patient's health data is collected by the patient themselves, a resident or a caregiver at their home, and then it is then sent to their provider or their nurse for monitoring review. And this is especially useful for senior living areas in order to prevent falls and keep a watchful eye on residents' vitals. And finally, there's mobile health. It's the use of smart devices like smartphones and tablets that use health-based software apps and that support continued healthcare. Many of these exist and they can monitor everything from their blood sugar and to their water intake, their daily water intake, and they really help to encourage a healthier lifestyle. And they can also integrate with a patient's personal health records if the app is designed to do so. Next slide, please. And some advantages of telemedicine: it can eliminate commute time for the patient and for the provider. It helps bring healthcare to rural areas with limited healthcare options. It increases the patient's engagement by allowing them to connect with their providers much more frequently. And providers can communicate and share information with each other more easily as well. And it also provides a better quality of patient care since patient follow-up will happen more often. In geriatric population specifically, it can reduce the burden and cost of certain travel expenses like especially with patients with mobility issues or that have no transportation. It can reduce the number of unnecessary hospital visits and reduce stress put on caregivers at home and just overall improve patient satisfaction. Next slide, please. Some barriers and limitations to telemedicine. It does rely on internet connection or phone reception if you're talking by phone, and some patients may not have access to these modes of communication. And if internet outage happens or like a phone lines go down, you're not going to be able to communicate with them, and you might not get the information you need. You can't see a patient's body language if you're communicating by phone, and because body language is very important, you will have to mostly rely on tone of voice to see how the conversation is going and maybe tailor the conversation around that. There's no in-person, and to go off of that, there's no in-person interaction with the patient. Some providers really do value this, and there's also a chance of data inaccuracy for patient-reported data, and because sometimes it's best to have some people would feel more secure having gathered the data themselves for providers, and it's also kind of easier for the patient to avoid conversation, sometimes for the healthcare provider as well, if they don't want to talk about something like this. This has happened to me a couple of times when I was doing medication reconciliation for polymomy, and the provider would just say, "Oh, I'm kind of busy," or "I have another call coming in, can I call you back?" And a good way to kind of avoid this is say, "Oh, do you have like, what would be the best time to call you back if you don't get back to me?" Can we go to the next slide, please? And I believe I'll hand it off to Joe for the rest of the slides.
Thank you so much, Tyler. So now that we have a general overview of telemedicine and how or where it's used in certain fields, let's take a look at some of the tools and platforms that are available for us to utilize. There are some common ones like telemedicine carts, telemedicine kiosks that would most likely be found in the inpatient setting, which allows healthcare providers to connect to patients that are admitted, usually equipped with a webcam and a monitor, and internet, of course. The most direct way, probably smartphones or telephones for direct phone calls with patients. Of course, if you have just a standard computer with webcam, you're able to do video calls to patients, and also the utilization of integrated healthcare software to transfer the information, patient information between providers also is a huge key. Certain applications that are used for this telehealth or telemedicine, it's really important to check with your institution to see which applications are marked HIPAA compliant, but some of the more common ones include Zoom for Healthcare, Skype for Business, and Microsoft Teams as well, which are good starting points. We can go to the next slide, please. So let's look at this medication reconciliation process kind of from a general standpoint and then get into the details of each step. We broke it down into 4 general sort of steps. First, the prep work entails going into the patient's records, reading admission notes, chief complaints, what's the status of the patient, past medical history, and if possible, locating an existing medication list on file, which is a good starting point for this process. Once you have all of your prep work done, the actual interview itself, being able to identify the different sources of information that you might have to contact, whether it be the patient directly or a family member or a caregiver, or even if you have to resort to contacting the primary care physician or the pharmacist at a retail pharmacy. These are all different sources that you may have to sort of contact. Utilize open-ended questions to get the most information out of the patient and also check for compliance, and also ask or inquire if the patient has a medication list at home or medication bottles around them that they can gather and give you the most accurate information as well. You should inquire about indication for medications, the dosing, how their adherence is, and also if they experience any side effects, and also if they have any medications that they discontinued, to check whether it was per MD's instructions or the patient just is not compliant or not adherent, excuse me. Once you have all your information collected from that interview, you can go ahead and gather it and begin the reconciliation process of highlighting any changes or discrepancies between your list and their list, and really seeing if you can make their therapy more efficient by doing dosage changing, discontinuing unnecessary medications, and also working on patient adherence. And once you have your updated list, once you've reconciled all of your information, you can go ahead and update your medical record, and also encourage the patient to carry a updated medication list with them to every appointment, or if they get admitted to the hospital as well, have themselves or a family member bring an updated medication list with them, which makes the process a lot easier in general. Next slide, please. So let's look at how telemedicine, specifically with focus on medication reconciliations, are used in action with examples from around the nation. In August of 2018, the New York Presbyterian Weill Cornell Medical Center integrated the telehealth into their emergency department so that they can conduct medication reconciliations in admitted patients. They allowed their pharmacy technicians or their pharmacy interns to conduct these virtual consultations via telehealth. And also for patients that are admitted, the nurses or patient navigators would wheel a cart or a kiosk, fully equipped with everything they would need for this consultation, so that remotely the healthcare professional can go ahead and conduct this medication reconciliation, which lasted about 3 to 5 minutes. In terms of the outcomes, of course, reduced travel time to perform the medication reconciliation due to the isolated nature. It allowed pharmacists more time to review for adverse reactions, drug interactions, and also it was expanded to the New York Presbyterian's Columbia Queens Allen hospitals. The program did see an increase in medication reconciliations by as much as 126% in certain campuses. Next slide, please. So we did go ahead and research some supporting literature for the use of telemedicine, and we'd like to highlight a few studies. In one study, Virtually Perfect Telemedicine for COVID-19 was a perspective article published in the New England Journal of Medicine that basically covers the different methods on which institutions are utilizing telemedicine, which currently have in place, and explained kind of in detail of how they're used during the pandemic. Second one was a systematic review entitled The Role of Telehealth During COVID-19 Outbreaks. And it analyzed and searched for studies that clearly defined telehealth use in all aspects of healthcare during this COVID-19 outbreak specifically, and concluded that telehealth may be a viable option to help solve these key challenges and barriers that healthcare providers are tasked with during this pandemic in terms of providing accurate healthcare to their patients. Next slide, please. Also, another one, the application of telemedicine to geriatric medicine. Really good article focusing on the use of telemedicine in the geriatric population specifically. Was a comprehensive review of literature that analyzed telemedicine in inpatient management, community care, and ambulatory care for geriatrics. And in conclusion of that article, it did entail that for management of chronic diseases, there are many reports of improved efficacy and as well as patient satisfaction with the use of telemedicine. Also, it's very important because this kind of gives a general idea or kind of a starting point for geriatric expertise or geriatric medicine to be able to connect to that specific patient population, which would be very beneficial for the patients. Next slide, please. So we did a sort of a slideshow to give you some tips for doing a medication reconciliation based on our experiences. And it kind of covers some of the points that we covered earlier. So it might seem a little repetitive, but the first one is having an open mindset and realizing that every situation is different, every patient is different, and it's going to be patient specific. So you have to have an open mindset, being willing to be creative in your approach. The next step, always create a plan, do your prep work, review patient information, identify your different sources of getting that key information, whether it be from prescriber or pharmacies, identifying and trying to locate home medications and medication lists, and also checking on the status of the patient and whether or not the patient is a poor historian or altered mental status that may likely lead you towards another source to contact, such as a family member, a friend, or a caregiver, etc. And then finally, once you have your plan, you want to go ahead and choose the most effective route to contact your patient, whether it be directly through a phone call or through a video conference or a video call, whether it be through Zoom, Microsoft Business, excuse me. But just make sure that it is HIPAA compliant, whatever method or route that you choose. And in some situations, you may be allowed to schedule an appointment with a patient for the future by contacting them earlier, seeing what is their preferred method and when they are most available, and then scheduling that for a time ahead is also a good strategy that you may consider. Next slide, please. And then finally, if your institution is thinking about integrating telehealth into their system, we did provide some telehealth resources available to you from the American Academy of Family Physicians. They provide a toolkit for your facility to build a telehealth program, a list of commonly used telehealth platforms available, and also practice guidelines for telemedicine that you can refer to. And here also is a link for a Telehealth Resource Center on the bottom as well. Next slide, please. Here's our references. And we also prepared a skit of a mock medication reconciliation that we will perform for you guys.
Next
Okay.
slide. Alrighty, so we have May, who is an 83-year-old female. She's very independent. She lives alone with a past medical history of hypertension, hyperlipidemia, diabetes, and acid reflux. Tyler is May's son, and he's also the caretaker in a sense that he goes to her house after work, and he takes care of all of his meds just to ensure that she's okay. And Joe will be the pharmacist completing the medication reconciliation today. So May has an appointment with the pharmacist Joe to follow up on her care. Tyler, her son and caretaker, will also be present in the call. May has already explained that she is unable to drive to make it to her appointment and that Tyler has been very busy and cannot take the time to pack everything and drive back and forth 2 hours to take his mom to an appointment currently. But they have agreed to take a quick meeting through Zoom. Joe has already done the prep work and has looked at her records. He knows that although May is independent, she is noted as a poor historian, meaning she has poor memory. And he also has a prior medication list already from a year ago. So let's go ahead and start. Scene start.
Good afternoon, May. Thank you so much for taking time out of your day to meet with me via this Zoom. First off, how are you? How are you doing today? How are you feeling?
Oh, I'm really good, Joe. It's nice to see you again.
Awesome. It's been a while since I last saw you. So before we begin, I'd like to catch up. What are some of your passions in life, May? What makes you excited? What gets you going throughout the day? And what do you enjoy to do in your free time?
Well, for me, I just want to keep on living the life I have now and being able to do the things without bothering my son, Tyler. I mean, I can still walk around, although it's just for a short while. I do still like to garden. And the most important thing to me is I want to go to bingo every week with my girls.
That makes me very happy knowing that you do enjoy socializing and trying to get out there in your garden and get some exercise. Very, very encouraging. And the reason why I asked you what really gets you going, what's your passion in life, is because what we're here for today, this medication reconciliation, plays a huge part in your health, which allows you to be able to be mobile and do the things that you love. So I would like to connect this medication reconciliation in a real world example for you to see how it's very beneficial for you and the importance of it. So thank you so much for sharing that with me. Basically, what's going to happen today is I have a list of medications on file that we have, and I would like to go through each one with you and see if there are any discrepancies or if there are any ways that we can make it as efficient as possible so that we can have you as healthy as possible to do these things that you love. Does that sound okay?
Yeah, that sounds perfect. But I'm actually not the one who takes care of my medications. My son takes care of that. After work, he comes
Oh.
here and he gets them all organized and reminds me to take them. So I guess you can ask him about that. Tyler?
Oh, hi, I'm here. Sorry, I'm late. I just got off of work.
Yeah. Oh,
Hi.
here he is.
Awesome.
Hey,
So
Joe.
convenient. Hi, Tyler. How are
Hi.
you doing? Thank you for taking time with us today.
Uh,
Really appreciate it.
yeah, thank you.
Um, I'm not sure if
sorry.
you heard of the whole process we're doing here today, but we're doing a medication reconciliation. And
Oh,
I was
yes.
wondering if you'd be able to help us going through
Yes,
these.
sorry, I will. Yes, I will. I have my mother's medications all here.
Oh, perfect. Do
And
you have a
yeah,
list as well?
yeah, I do. I do.
Awesome.
Let me just,
Perfect.
yep. Yeah, so whenever you're ready, I can
Cool. I'll
let
just
you
go
know which
through
one.
the list that I have and I'll see if it matches up.
Okay.
So the first medication that I have here is lisinopril. Is your mother currently taking lisinopril?
Let's see. She's actually not taking lisinopril anymore, and if I remember
Oh,
correctly, she was actually switched over to losartan. Um, she doesn't take lisinopril anymore because she started to have really bad coughs. So her doctor said switch it to losartan.
okay. So it's per doctor's instructions for that.
Yes,
Do
yes.
you have the dosing for that?
Oh yes. That'd be 50 milligrams PO daily for her blood pressure.
Perfect. Perfect. Next medication I have, metformin.
Metformin, yes, I do have that too. That's 500 milligrams, one tablet by PO BID for her diabetes.
So twice a day.
Yes, twice a day.
How about atorvastatin?
Atorvastatin, yes, she still takes that 20 milligrams, one tablet by mouth daily.
Perfect. And the
For
final drug that I have on this list, the pantoprazole.
yes, pantoprazole, yes, she still takes that 40 milligrams. She takes it as she needs it for her acid reflux and only takes one tablet whenever she does have acid reflux.
Okay, so it's just to clarify, it's more of an as needed basis, the pantoprazole, just
Yes.
when she experiences. Okay,
Yeah, I don't usually get acid reflux too much, maybe about once or twice a week, and I only just take that one tablet.
perfect. I'll go ahead and update that and note that on my list. So for the most part, my list is fairly accurate. There are a few discrepancies, but nothing extremely major. May I ask, do you experience any side effects to any of the medications that you take?
No, I haven't experienced any side effects. I feel great.
Can you confirm that, Tyler? Have you noticed anything?
I can confirm that she doesn't seem nothing out of the ordinary happening with her.
Perfect.
Yeah.
Awesome. Thank you so much. If you do experience any side effects, be sure to note that on your list as well. That's something good to bring up with your provider if you do have future appointments. As far as other over-the-counter medications or supplements, do you take anything extra that I didn't list, May?
Oh, well, I did get a recommendation from my girls during bingo one time, and they told me that I should take a bioastin. So I
Oh,
take
okay.
the bioastin 12 milligrams, but I only take one capsule.
Okay.
And then
Bioacid, anything else?
I think other than that, I do have my ibuprofen for my pain sometimes. You know, some days my leg hurts, and then other days my back hurts. So
Mhm.
I do take ibuprofen.
Perfect. And how do you take the ibuprofen? How often? How much?
So I have the bottle here with me. I take ibuprofen 200 milligrams, and I usually just follow the directions on the bottle. So I think that's like 2 tablets every 4 to 6 hours. But I usually cap it at the 4 tablets though. But I do take it pretty often, at least every other day.
Okay, at least every other day. Okay. Since you do take it often, maybe we can consider a switch to something a little bit more safe in terms of bleeding risk. Would you be open to maybe switching to Tylenol? Have you ever used Tylenol before?
I used to use Tylenol before, but I don't know. Is that better?
Yeah, especially for um, patients above the age of 75, a little bit elderly, Tylenol may be a little safer in terms of risk for bleeding. So we can possibly come up with a plan for an alternative for the ibuprofen. I'll go ahead and note that, as long as that's okay with you.
Yeah, no problem. Just let my son Tyler know he's got to get the medication for me because I can't get it.
Okay. I'm sure that won't be an issue, but if it is, we can go ahead and plan that as well.
Of
What
course.
are
Okay,
some other
perfect.
concerns for me that you have?
I don't have any concerns. Tyler, is there something wrong?
No, no, nothing wrong. I guess we can try out the Tylenol. Although I didn't notice she was bleeding any more than usual. Yeah, we can try out the Tylenol, see how that goes.
Thank you so much for your time. I really appreciate it. Once again, always make sure you update your medication records if you do add on additional supplements or have any changes from the doctor, and make sure to bring that to all future appointments if possible as well. Thank you so
All
much for your
right.
time, both of you.
All
Yes,
right. Thanks, Joe.
Thank you so much. Bye-bye.
Bye.
Bye-bye.
And scene.
Thank you so much, everyone.
Yes, thank you, everybody.
Alrighty, and then you can just go ahead and go to the next slide. And we're basically done. Did anyone have any questions for us? Thank you.
Yes, bravo, guys. That was fun. But we do have questions. I think there's it raised a couple of issues that I know Sarah Tompkinson, she's one of our social workers here, and one of the issues she brought up was the role about health literacy and assessment of health literacy. How do you guys go about doing it? And do you think there's a role for social work in health literacy?
One second. Yeah, I do believe health literacy is an important aspect that we need to focus on because we do need to make sure that we get the most appropriate information and updated information and correct information. In terms of social work, yes, it could play a huge factor in kind of analyzing the patient's home life, what their situation is, and also their status. Tyler, would you like to add anything?
So, hey Joel, thanks for that. So when I used to work at the VA, like the social workers, even now, social workers are a huge source of information and definitely a critical member of the team. We used to get together to kind of go over like the patient's social situation and gives us a better situational awareness as far as where the patient's at and perhaps some of the needs. And like Joel was saying, it goes into our pre-work and being prepared for this medication reconciliation.
Great. Can I invite Mary maybe or Sarah to unmute and chime in about what they do with that before they even get to the pharmacy?
Hi, this is Mary. So just, looking back at you can hear me okay, right? The people that I mostly got referrals on, they would be in their late 80s and 90s. And I can't recall only one person who had a laptop. And most of them just had landlines. They didn't even have cell phones. So those people, it would be really difficult to do this with. And just, the value of having a nurse or a social worker that can make a home visit when it's possible. You can just pick up so many things. Like I'm thinking of one lady in her 90s that was referred by the PCP. She didn't have any kids or anything, and she was getting demented, but it hadn't been diagnosed yet. But anyway, when I went there, she had prescription bottles covering every countertop, tabletop, everywhere in her dining room. There must have been hundreds of prescription bottles, and she was very confused and forgetful. And person like that, it was very valuable, just an example, to go there and see what was there and be able to tell the doctor that she had bottles there from 30 years ago. And it might be really hard for her to figure out which bottle she should take today. So that's just my comment. That I agree that this telehealth is really great and has a lot of advantages, but there's certain times where there's still the advantage of making the home visit.
Sarah,
Hi, this is Sarah. I just want to commend the pharmacy interns for doing a fabulous job. I think the biggest takeaway for me is, and maybe for all of us, was just having that historical background on the benefits and values of telemedicine and telepharmacy. I had actually a follow-up question. I was the one that was asking about health literacy. I guess what I'm asking is how, for people that maybe have a 4th or 5th grade education level, how can you best try to communicate the importance of the medication reconciliation. Although in your skit, you all did such a you did a wonderful job, but you had quite intelligent caregiver and kind of unusual to see the client so well versed, but it was great.
So, hey Sarah, definitely we do have some patients with very low health literacy, and I think one of the important things of medication reconciliation, or just in general, is meeting the patient where they're at. And so at the end of the day, we have to look at what we're trying to accomplish with our medication reconciliation process. And sometimes a victory is just getting a good med list, as good and as accurate a med list as we can. We may not necessarily be able to get the indications and talk to them about their side effects and do a little bit more of an advanced med rec. But at the end of the day, if all we can get is what are your current meds, then I think that could be a huge victory in and of itself. So unfortunately, patients with poor health literacy, sometimes I just have them bring all your meds, just clear out your medication and show it to me. And if you have a camera, you can put it on the screen, and then I'll take it from there. So we definitely have to adjust and adjust fire and adapt. But sometimes, just show me what you're taking, put it on the screen, I'll take it from there.
Yeah, in fact, I want to comment that this virtual world now has given us a window into doing these almost virtual home visits to do the MedRec, where they can just bring the camera to the medication cabinet, basically on the counter, and show you one by one what it is. And actually, they can actually show you how they take it, if they're able to open the bottles or anything like that, or do they actually use a pill box, things like that. What is your strategy? That's one of the benefits, I would think, of switching over to the telemedicine virtual way of doing MedRec. I had a question here. Are pharmacies offering home delivery or have the patient on a mailing list for drugs to be delivered? Do you know?
So you guys can, if you guys want to chime in and add more clarity, you can surely go ahead and do so. But some of the major chain pharmacies do offer home delivery. Some companies like Express Scripts and even your health insurance may actually dictate that you use home delivery for your maintenance medications. For some of the more urgent medications like antibiotics, you may still need to go to the pharmacy to pick that up. But a lot of companies now are leaning towards home delivery, especially for maintenance meds, because it is cheaper. And as far as them being on a mailing list, they don't really not necessarily a mailing list per se, but I believe it's synonymous with like the auto refill function, where you can just click that auto refill and they'll send you your bottles at the end of that time frame. Usually about when you're 2/3 of the way through. I haven't tried it myself. Although it looks pretty cool. Amazon has a home delivery service called Amazon Pill Pack. And basically what it does is it just puts all your pills in one simple pill pack, and it says morning, noon, and night. And it's all in one pill pack. I haven't tried it myself. If anybody has used that, hey, please share. I'm kind of curious.
Hi, sorry, this is Ricky Hong from QCIPN. Can I chime in there?
Sure, definitely.
Yeah, so I would really advocate, personally at QCIPN, we tend to utilize a lot of 5-minute pharmacy. A, they're local, and B, they do blister packs like that as well. They are very, very, very easy to work with, super friendly staff. They do home deliveries. Yeah, I really, really love them. And they've been really good since pre-COVID. There's also IAEA pharmacy that does blister packs, and they label them, and then they do them with easy opens. So, you don't even have to pop the blister pack. It's like a peel sticker. They're labeled really well. I'm always about supporting small and local rather than Amazon, sorry. But yeah, I mean, that's a good resource to have too. But yeah, I highly, highly recommend 5-minute pharmacy or the IAEA pharmacy if you wanted to do pill packs and things like that.
And also another great company in addition to 5 Minute Pharmacy is Pharmacare. They're another great local company that do blister packs as well. And they also do some home delivery as well. They'll schedule out some home deliveries, and that's a possibility too. So again, yeah, Pharmacare Hawaii, another great local company I work with, and great people. So I think that, you know, a lot of times when in supporting local, definitely if there are issues with blister packs and pill packs and needs, being able to more tailor the needs of your patients from a pharmacy standpoint. Sometimes the small local community pharmacies like KTA, Times, 5 Minute Pharmacy, and Pharmacare can make adjustments in their business model to kind of help accommodate those needs. And they do them wholeheartedly. The blister packs cost money and they take a lot of time, but that's a service that these pharmacies do for their patients because that's in the best interest of the patients. And then so Sarah mentioned, do we foresee the insurance company will consider reimbursement for telepharmacy? That would be totally cool. Unfortunately, pharmacists, we're banging on the doors of Congress to try to get reimbursement for our services to include medication reconciliation and chronic disease management. But right now, getting reimbursed for our services to include medication reconciliation hasn't bear a lot of fruit for us. When we do it, we usually have to bill it under somebody else. So for example, like we'll do the med rec and then we are working under or with a physician who will bill for that service and get reimbursed.
Yeah, so I just was kind of wondering also, like, given that we can't exactly call our local pharmacist to help our practices do a med rec when we're concerned about a patient because it's going to be time intensive. You know, what is the role? How can we call on, you know, our nurses, service coordinators, social workers? I'm gonna just open it up to you guys out there in the community and see how have you been able to help with med reconciliation?
All right, so I can talk again. This is Ricky from QCIPN. Yeah, our program does the med reconciliation all the time with our nurses, social workers, our SWAs, our MAs. I have to do medication reconciliation all the time for the mental health integration program for where we do collaborative care with the psychiatrists. So I really empathize with the students and they say they have to really, you know, unfortunately go through a lot of techniques, whether it's patient support historian or, you know, we go in the home and we find 100 bottles. Those are all very familiar stories. And then really it's a lot of detective work. And so, yeah, it is time consuming. And sometimes you really can't even trust one source. Like even providers are really guilty about providing outdated information because some providers are not good about discontinuing a medication on their meds list in the EMR. So you call and you're like, hey, what are you prescribing them? And then they say all of this. And then, you know, but if you look in the notes that they said discontinue it. But because they didn't stop it on their EMR, they're just reading off of a list. So patient's not supposed to be taking that, or, you know, because they didn't discontinue it or put a stop order, pharmacy just has it on automatic refill. So I've definitely had patients, you know, even though the doctor said to stop taking or whatever, because they didn't put in a stop order, pharmacy longs is the big guilty, what I'm looking at right now, will just keep sending out automatic refills. And, you know, again, if the patient's a poor historian or doesn't really know, they're just like, oh, long's called, I'm getting a refill. Okay, I'm going to take it. And they're not supposed to be. And then I'm like, oh my God, please no. So these are the challenges I've run into. Yeah, it does take a really long time though. And yeah, I can't imagine MDs having to do it. So QCIPN, we're one resource. I would probably tap into care coordination, insurance. If not, like, especially if they have Medicaid, getting a care coordinator on board to help with that. A lot of the insurance companies have clinical pharmacists on staff too. Yeah.
You know, definitely. And sometimes, you know, with medication reconciliation, like you might have to just start from scratch, you know. I mean, you might have a list of meds, you know, 2 pages long, but sometimes you got to just start from scratch and ask the patient, what really are you taking? So I have a list of 15 meds, but if you're only taking one, then okay, let's start there. Because really the other 15 don't make any difference, doesn't do anything anyway, just being on a piece of paper, right? Or sitting in your cupboard. So if we can figure out what are you taking, and then we can go from there. I find that it can be very, if you don't do the medication reconciliation right and you don't ask the patient, what are you really taking? It can be very dangerous, especially when we come to the hospital. So I've had patients on like 50 units of Lantus, and you know, we ask the patient, oh, okay, well, how much are you supposed to be taking? They're like, oh, doctor says I'm taking 50 units. And okay, how much are you really taking? And turns out the patient's not taking the insulin at all. And so you can see what the problem is all of a sudden you think that the patient should be on 50 units who's not even taking insulin at all. And then we give them that 50 units and all of a sudden they bottom out. Why? Because the dose kept going up. We thought that the patient was compliant or adherent to their medication. We keep increasing the dose because we think that it's not working and they need more insulin, but in reality, the patient wasn't taking it. So really getting a good medication history and figuring out how the patient is taking it and if they're taking it is very, very, very important, especially coming into the hospital when they're gonna pretty much get the med on time.
Great. Yeah. Any other, I know there's a bunch of primary care physicians out there. I saw you, Eric Yee. I'm going to call it, yeah, a little bit. What is your approach on med reconciliation? How do you go do that practically from your office? If you know, who do you call on?
If I'm doing telehealth, I'll usually go over it with the patient at the time of the visit. In the office, my medical assistant usually goes over it initially, but I cross-check it because sometimes she'll miss things that, you know, are no longer on the list or on the list, but not visibly on the list. You know, the patient's taking it. So it's a lot of give and take. Got to, you know, double check things all the time because they often are taking over the counter things or holistic things or things from their friend or even their spouse sometimes, you know.
Yeah.
So that makes it real challenging.
Yeah, great. I appreciate that. Anybody else have experiences to share? Yeah, I want to also just thank Ricky Hong for that shout out to the insurance companies. I'm really just calling on them. You know, they're paying for this stuff. They actually have a vested interest in making sure that the meds are taken correctly. Otherwise, bad things happen. Right? That's one of the most common reasons for hospital admissions and readmissions is med errors. So, yeah, if you're concerned, you know, call on them and say, well, you'd hope, but call on them and ask them. You know, you have a clinical pharmacist. Can you help me do this? Some places have that, and then like sounds like, you know, use of the MA, or like maybe if you have a social work who's concerned, you know, about health literacy and stuff, at least get it ball rolling started. Sounds like another strategy.
I was going to say the other challenge I have is, you know, we're in a multi-specialty group at Straub, and sometimes specialists will change a dose or something, but they don't change it on the med list. And that can be a real bummer because, you know, you say, okay, well, you think they're on metoprolol 25 and your pressure's high, so you go up to 50, right? You know, but they're already on 50 or they're actually maybe even on 100, and you didn't know that, you know, so it might be a dosage decrease or something, you know.
Yeah.
So it behooves the specialist to make sure that they're making the changes on the EMR real time when they make a change or a suggestion of a change.
Yeah.
Otherwise, it's garbage in, garbage out.
Thanks.
Yeah, Dr. Yi, that I hear you on that. I think that's an issue that I've seen not only at Straub, it's just a very difficult process overall with different EMRs. Even, you know, at the VA we had the same thing. I'm sure Queens and multiple different institutions have the same challenges as well.
Okay.
Great. Yeah. Any other providers want to share their experience with telemed reconciliation? Any good ideas? Okay, I had another question. I know that you shared a study about med reconciliation at the ED at Cornell Medical Center. I'm not exactly sure what happened with that. Did med reconciliation happen at the ED, or did it happen after discharge from the ED and the ED pharmacist can do this for you? Can you, does this?
It happened, so the medication reconciliation occurred before so they arrived to the ED, and then the medication reconciliation would happen before they get consulted by the ED doctor.
Wow, so they just went ahead and called the consultant pharmacist in the hospital to do that. They just came in on their video camera.
Yeah, they came in on the cart.
Yeah, on the computer on wheels kind of thing.
Mm-hmm.
Yeah, even at Polymomi, that was one of the huge pushes and one of the primary roles of the ED pharmacists. They actually have a pharmacist in the ED, and one of their roles is to drive the medication reconciliation process.
Great. Anybody else have any good or bad experiences with or problems they found with MedRec? Okay, I know that it happens. Transitions of care is really tricky, and so I kind of wonder if there's a system, you know, that we can call upon pharmacists to help us when they transfer from maybe even, you know, hospital to nursing homes, you know, MedRec wise or anything like that.
Yeah, for me, that'd be real helpful if somehow, you know, the EMRs were interlinked, because I got a patient that went to Straub and then she went to the Plaza, and all the meds at the Plaza were different from what we have in the list at Straub. And is multiple faxes later and multiple frustrations later, you know, and they want to ask every little minutia question about drugs that aren't even on your list, you know. It's pretty frustrating.
I think this is the perfect time now that we can't really see, you know, everything in person. It's very hard to access stuff. You know, I think it's somehow we've got to leverage and work with the payers to see, we got to have these pharmacists help us all out with these transitions of care, and to maybe, since now, you know, it's proven we can actually have pharmacists doing telepharmacy, you know, just get them on the phone, get them on the video, and help us do real time, do this in advance before our clinics, before our admissions, before our transfers. That would just be, I mean, I could just see it. It would just be beautiful. But I guess that's a dream. Yeah. Okay, great. Okay, great.
Just another question,
Oh,
Sarah. So one last question. I know they talked about the ED, but
yeah.
more and more people are going to urgent care clinics. And
That's,
as you know, that's like the way, that's the future. That's the way of the future. The medical centers have been opening urgent care clinics. Does Chad know, or any of the students, whether or not medication, how do they have like pharmacists available to do medication reconciliation in these hospital-based urgent care clinics in particular?
Well, you know, I'm not too familiar of the practices of the urgent care clinics. I do apologize. But a lot of the urgent care clinics are singular practices and don't have a pharmacist or a pharmacy presence organic to that practice, unfortunately. Yeah.
Okay,
Beyond
but
that,
good
I'm not.
idea.
Yeah.
Great idea. We should bring it up, right? Okay, so anyway, it is 1:00, so I just want to just thank everybody for joining us. And in order to get your CME credits, go to our webpage, and if John, you could post the link for the online evaluation form, that would be great. Just indicate your type of CE you would like, and also please include any comments or suggestions for future programming. Our next topic next month, December 9th, will be depression and dementia screening during COVID, and it will be presented by Dr. Brett Liu. So hopefully you can join us as we talk about that as well. Thank you, everybody.
Thanks, Ida.
Thank you.
Thank you, everybody.
Thank you, everybody.
Thank you.